There seems to be many acronyms used, such as LGBT, LGBTQIA+. Which acronym is more reflective, or accepted by the LGBTQIA community, and what does each letter stand for?
LGBTQIA is the most preferred and accepted acronym currently, and the plus at the end is inclusive of people that are possibly not in the acronym. The L stands for lesbian, the G stands for gay, the B stands for bisexual, T for transgender, Q for queer or questioning, I for intersex, and A for allied.
We do education and advocacy for gay, lesbian, bisexual, transgender, intersex, queer questioning, two-spirit, same-gender loving, pansexual, flexual, not straight, not labeling, straight-ish, straight so far, straight with options, straight but stuff happens. Gender bending, bigender, pangender, agender, asexual, non-binary, and other sexual and gender minority youth. As you can tell, there's a lot of words. Fortunately, I think that what's most true about all of this stuff is that you need to know the basics, but once you know the basics, all you have to do is keep open rather than keep up. Right? We can't keep up. The words are always changing, but we can keep open and listen to what people say and respond to what people are telling us.
So emails sometimes have pronouns next to the person's signature. To name a few: she, her, hers, they, them, theirs. What do they mean?
Some people do it as a sign of solidarity for transgender people, that we all should utilize, our pronouns because we all have them. I think it often avoids miscommunications and mistakes. I think for trans people, it's something that we can do to let people know that is the pronoun that we use before they even meet us. When people come in to meet me, sometimes it's hard to tell what pronouns somebody uses, right? You can't tell on the phone what pronouns I use. You can't even tell sometimes coming in and looking at me necessarily what pronouns I use. They're easily accessible on the internet. I think that probably the only ones that, aside from for gender neutral people or non-binary people, might use they, their pronouns or ze, their pronouns. Or my favorite is fey, fair, because I'm like a radical fairy kind of person. So, I think there's a whole list of gender neutral pronouns that are out there if you're looking.
People are always wondering about pronouns and what's the right pronouns and how do you ask about pronouns and all those kinds of things. So what a lot of people are doing right now is putting their pronouns at the base of their email signature as a message to people that you've thought about this, that you know what it means, and that you're open to hearing other people's pronouns. The fastest growing identities, especially for young people and young adults, is an identity that's called non-binary. So neither male nor female, but something more or different than that. I've had young people say to me things like, I've always known that I'm not a girl. But just because I'm not a girl doesn't mean I'm automatically a boy, right? And so for people who don't identify as either male or female, he or she doesn't work as a pronoun. And the most common pronoun that people are using now is they, them, and theirs as an individual pronoun.
There are other pronouns that people use. Another common one might be ze, zer. People sometimes use that instead of they, them pronouns.
But if you went to Wikipedia and you looked up gender pronouns, there's over 100. People are really trying to find words that describe an identity that we don't really have words for in English.
How should we ask anyone that we are interviewing on how they should be addressed?
I really appreciate that question because we talk a lot about what it means to be person-centered. And I guess what I'd say about that is ask anyone with whom we have contact what their preferences are. Starting there, it's a pretty simple thing, but it is a respectful way to start any kind of conversation. And because we're in service, I think that that's always advisable.
The best way to ask people how they want to be identified would be to introduce yourself first with your pronouns, and then ask, what are your pronouns?
If it's a stranger and somebody I don't know, sometimes I'll say, or a new patient, I'll sit down and I'll say, hi, I'm Dr. Demadon. I use she, her pronouns. Do you have a preference of pronouns for me? Sometimes
you'll hear people say that if you don't know, ask. I have a problem with that as a strategy, because if the only people we're asking are the people that we wonder about, then we're using some sort of a stereotype to decide who to ask. So we need to figure out a way to ask everybody, because especially with non-binary folks, that what you see, how people dress and express, may or may not reflect who they are and what their internal identity is. So we have to figure out a way to ask everybody on intake. And the easiest way is to use open-ended questions in the beginning of your intake process. So you'll say, I noticed that your legal name is this. Is there a name that you prefer that I use? So trans folks or people for whom the name on the birth certificate doesn't relate to who they are can offer an alternative. But there's also lots of people who use nicknames. People may want you to say their name correctly, right? And so asking them, how would you like to be addressed? And then following up with, my pronouns are she, her, and hers. What are your pronouns? People who've thought about this are going to go, wow, thanks. My pronouns are this. For people who've never thought about this and haven't been asked about their pronouns since 3rd grade, they're going to say, what? And so then it becomes a teachable moment that you say, well, we don't make assumptions about anybody's identities here. So we ask everybody about their pronouns.
What should we do if someone has introduced themselves with their pronouns, but we make a mistake?
So you have a little bit of flexibility, because it's going to take a minute to wrap your mind around a new language that you didn't grow up experiencing. If you make a mistake, notice, correct yourself, apologize, and move on.
I mean, I think it's sort of like any other mistake that somebody would make. You just apologize for it. I think, I think that the sheer apology for it to a trans or gender nonconforming person is great, that you're acknowledging that you made a mistake and that you're going to try to correct the behavior. However you need to do that to make sure that you don't do it again, that would be what I would focus on. I think the correction of the behavior needs to be something that is paid attention to, because if you do it every single time that you see somebody and they've already corrected you 4 or 5 times, then I might start to wonder if you're doing it on purpose, right? But I think once or twice even, and just apologizing and saying you'll change for it.
The best thing to do in that case would be to acknowledge that you've misgendered them by using the wrong pronoun, own it, and then move forward.
When in doubt, use the person's name, because then you're not, if you already asked them what name they want to be called, just use that, and then you don't have to worry about it.
What is the difference between sexual orientation and gender identity?
When I do any trainings, I tell people, if you learn nothing else from this training, this is what I want you to learn. Sexual orientation, the way that I look at it is, it's who you go to bed with, okay? Gender identity is who you go to bed as, all right? So sexual orientation develops in our teens, right? Or maybe in our late childhood, and it's a attraction to somebody else, whether it's emotional or physical attraction to somebody else. Sexual orientation has nothing to do with gender identity at all. The label may have something to do with what gender you are, but gender identity is not associated with sexual orientation in any way. Remember, I don't need to give you a pill to make you gay. I don't need to give you a shot to affirm your lesbianism. Most transgender people do require some sort of medical affirmation or treatment. That's why that population of people, we need to have a better understanding. More people need to have a better understanding of why gender identity is so important to be protected in medical spaces.
We'll start with gender really quickly first, okay? So there's at least 3 elements of gender. So gender expression is what the world sees when it looks at us. And a lot of times human beings make assumptions about the gender of the person that they see based on how they're dressed. So, your hair, how you move your arms, the sound of your voice, all of those things. Gender expression is the outside communication of our identities. Sometimes it matches our internal identities and sometimes it doesn't, right? But it's what the world sees when it looks at us. Gender identity is about who you know yourself to be as a boy, a girl, a man, a woman, or something more or different than that. Sometimes, for reasons we don't know, a child understands that who they are is not the same as other people see them to be. And so, for example, it's interesting, when I was little, the people often read me as a boy. And the research says that if you look at somebody and you can't instantaneously determine whether that person, make an assumption about their gender, if you look at somebody and you can't instantaneously go, that's a man or that's a woman, people start with the presumption that the person is male and they look for feminine overriders. And it takes as many as 3 feminine overriders to override the presumption that the person is male, right? So when I was 5, I just didn't have enough feminine overriders. I don't know why, right? So I would be walking around in the world and people would say, hey, little boy or young man, things like that. And every time that happened, I felt embarrassed, but I never thought I was a boy. I knew I was a girl, even though they didn't see it. And that's the difference between gender identity and gender expression. You know who you are, whether the world sees it or not. The third element of gender is the sex that you're assigned at birth. And that is solely done by the look of your genitals. That when you pop out, they go, it's a boy or it's a girl. And if your genitals look the way they expect them to look, they assign a sex and off you go. But we now know that intersex children that are born with chromosomal or reproductive or genital differences, are as common as red hair. Right? 1 out of 2,000 babies is born with some level of intersex condition. And so even at the level of biology, it is so much more complex than simply this or simply that. Sexual orientation is about who you're attracted to, right? It's about who you have feelings, romantic and erotic feelings for. And people can have attractions towards one gender only, so straight or gay. People could have attractions towards multiple genders, so bi or pan. Bi, that term means two. Pan just means all. And so people who are attracted to people regardless of gender or can be attracted to all different genders might use the word pan. And then some people don't have sexual and romantic attractions, and that's asexual. So that's another level of identity.
How can we, DSS, provide better access to services for the LGBTQIA community?
I think to support people who self-identify in this way, it's important not to make assumptions about the composition of a family. Again, going back to those principles and practice of person-centeredness, it's good to just ask people how they define their family. That may be a family that includes same-sex partners or a married couple. It may span generations. It may be a blended family. And in the same way we would do for any person, I think asking about how that's defined by that individual is helpful.
So there's a couple of ways. Number one is to ensure that equal treatment occurs across the board for LGBTQIA plus people. The same healthcare spaces, the same healthcare opportunities that apply for cisgender heterosexual people apply for LGBTQIA plus people. Queer people have traditionally not had a particularly good time of it in medicine, and so I think that DSS can try to help ensure that offices and providers are competent in LGBTQ medical issues, particularly for trans people, right? That DSS can ensure that all of the services that are necessary for medical transition are available to trans people. My experience is that DSS is doing a pretty good job on the sort of making sure that the services are accessible. The providers who provide the service, that is something that I think needs to be expanded pretty significantly.
It's very important to know what is around you in your area, know what services are available, know the providers that are available in the area, so that when you are servicing somebody in the LGBTQIA plus community, you know who to refer them to, what services they provide, and you want to make sure that you are referring to the best providers out there specifically for the community. The needs are different, and it's important to know that the needs of the community are different so that you can then refer to the right providers.
You need to think about your environment. So how do your clients access DSS? Is it on the web? Is it through the phone? Is it in an office space? How do those places reflect the diversity of the people that are coming for services? When people come in, is there representation in the environment that lets them know, a safe zone sticker, for example, or something that lets them know that people have thought about this and that they're welcome there? What are some of the ways in which you do your intake of people that reflects all of the ways that they are? There's online services that are available, so that if you have a client who comes in who needs access to something, you should be able to have the information you need to be able to find somebody who can meet that person's needs.
By including on the forms more options for sexuality and for gender identity. Also, I think right from the very beginning you set the tone when you're doing intake or you're talking to the client for the first time, you set the tone for how welcoming and inclusive you are.
How can we help to foster an inclusive and comfortable environment for LGBTQIA+ employees and individuals we serve?
The best way to make sure that everybody, employee as well as client, understands its inclusive environment is by the messages and cues and clues that are being sent all around. So you have messaging done all the time in your environment. You might have flags that are rainbow flags or transgender flags. You might have pins that people wear that say pronouns or might have those flags as well. There's messaging going on with pictures and images around. There's also messaging done in communication on your website through communication with employees and with clients.
That's one of the reasons why at least my healthcare organization was even made, is to try to foster that. If you look at our registration packet, for instance, and we have, what were your assigned gender at birth? What is your preferred gender? What pronouns do you use? What's your preferred name? What's your legal name? And we explain why we use legal name. We ask people about their sexual orientation. There are 6 different options for your gender identity. I think that those things help foster an inclusive space for queer people. I think recognition that they exist is really nice. Also, hiring trans people, hiring queer people to work in your space is something that is inclusive, because when a queer person comes in and they meet another queer person working behind the desk, or their provider is queer, or whatever, they feel comfortable. They feel more comfortable than they would have felt perhaps without that.
To make sure that as a whole, the Department of Social Services is inclusive, is culturally competent, and that the education continues, and it's not just a one-shot deal. So that we do this, we provide a training, and then we're done. It's important for employees to feel that they are represented, that they are included, that people understand who they are, and that they are accepted completely for who they are.
Recognizing that families come in lots of different shapes and sizes is, I think, an important thing. And allowing people to bring as much of themselves to work as possible, right? So if different gender couples can put their wedding photo on their desks, then same-sex couples can do the same thing. If different gender couples can talk about their families and their relationships and their children and their spouses, then same-sex couples can do that as well. So looking for ways in which that people are able to bring as much of themselves as possible to work.
In regards to your experience at DSS, what sort of inclusive measures have you seen implemented?
I think there's other matters that I think we'll be reviewing and determining how to move forward with. Composition of family for purposes of our applications. I think the legislature and the governor's office are interested in examining how offices can, move past a gender binary that only reflects male and female. And also cultural practices like asking people how they'd like to identify themselves from a gender binary standpoint. These are all things that I think DSS could usefully keep examining and moving forward with. DSS has done a lot to really broadcast information about the importance of diversity as it concerns our community. I particularly want to point to the work that Office of Skill Development, OSD, has done in developing cultural competency curriculum and really being very thoughtful about building that in. I think there's also work that's been done by HR to make sure that people know the rights and opportunities that LGBTQIA people have in the workplace in terms of hiring and workplace protections.
What recommendations would you make to better affirm the rights for employees who are part of this community?
As our culture kind of moves forward in recognition of rights and protections for people, one thing that I think we will be looking at is how to be as inclusive as possible in terms of how we define people from a gender identity standpoint, families and marriage. What we can do more of is opportunities for learning, opportunities for dialogue, also understanding how people may not feel that they fit into our structure, like even our application structure that asks people to identify themselves on a gender binary, either male or female. There's some opportunities there. I think there's some opportunities also to keep identifying that for any group that's not part of the majority culture, just attention to needs. So those are things I think would be useful going forward.
Now let's talk about some misconceptions. What are some of the misconceptions about people in the LGBTQIA community?
We just said a whole bunch of acronyms, LGBTQIA+. That's a lot of different types of people that are under this umbrella of LGBTQIA+. But members are very different and very diverse across the LGBTQIA community. It's a huge misconception to think that the entire community is the same and that everybody is included and accepted equally across the board, and that really is a misconception. It's very important that the L's get represented, the G's, the B's, the T's, the Q's, the I's, and the A's get represented and included as much as possible. Another misconception about the LGBTQIA community is that there's only one way to be LGBTQIA, that there's only one way to be lesbian, that there's only one way to be trans. And that's not true. Each individual has the right to present themselves the way that they want to be seen and the way that they feel. And that needs to be accepted as well.
I guess that the first one would be that you have the right to turn me away from your place because I'm queer in your medical space. Like, I think nothing about being in the LGBTQIA community is so challenging that you as a medical provider or office can't care for us, right? I think there's nothing so unique or crazy or different about us that we don't deserve the same sort of healthcare that everybody else deserves. Also, I think sometimes media kind of portrays like gay men and queer LGBTQ people as like having this like fun and fancy-free lifestyle and like driving BMWs and Miami Beach and stuff. And like there is a portion of the community that has significant privilege, but overall, queer people suffer from lack of housing, employment, healthcare, at much more risk for HIV and substance abuse, smoking, all those kinds of things.
One misconception I would start off as the obvious, that transgender people cannot be clergy, or that religion isn't a place or a welcoming place for people who are transgender or have transgender experience. And that's just simply not true, as I'm living proof of that. But faith is very important to people, all people. And so having a place to go, a place to worship, and clergy that welcomes and understands that God is about love, that it's important to understand that. Another misconception is that transgender people are gay, and anyone can be any sexuality. There's a whole spectrum of sexuality, and so transgender people can be gay, straight, and all sorts of sexualities. So there are a lot of misconceptions, a lot of stereotyping going on that's leading to a bias and ongoing discrimination and bigotry out in the social environment, and I imagine for DSS as well.
For any group that is not part of majority culture, there can be ideas that there is a sameness in the group. There's an incredible range of perspectives, lifestyles, living situations, philosophies among people in my community, just as there are for any other group that's outside the mainstream. And so I think making an effort to understand that people are individuals, may not hold the same views, even about something as fundamental as marriage rights or workplace protections in terms of what's a priority, that's helpful, not to kind of judge people as though they're just part of a group that all holds the same opinions.
How do I think that those misconceptions could be corrected? How about you just get to know some LGBTQIA people and have them as your patients and see their reality, and you can do trainings on the actual reality for your offices or for the people you work with or your friends. I mean, my husband hates me so much because everywhere I go, I'm like, well, did you know that 1 in 4, your chances of a Latino young MSM becoming HIV positive are 1 in 4 of their lifetime? And it's like some stranger at the grocery store. But I feel like if you have the ability to affect a population of people, you should utilize that sort of ability to help train people and teach people about the reality for us. I think that to me is so powerful of a way to change misconceptions about people, is to teach their parents these things, because that's who has the most impact over how a kid's going to behave eventually in their life. And we don't do that, right? We don't teach kids about queer sex in school in Connecticut. So, we need to change all of that in order to sort of really have the change in misconceptions.
We assume that somebody is cisgender, and cisgender means that you are physically as well as your gender identity, which is an internal knowing, match. But you can't assume that people have that as congruent. So you might not know that you have somebody who's transgender that you're serving. And you might assume that everywhere you go, you haven't met anybody transgender, you haven't worshiped with anybody transgender, or in the stores or in education or any of your clients, but the fact of it is, we're everywhere. So you can't assume that. And with that, don't assume relationships. So you never know whose relationship or how relationships are constructed, and each person is looking for a satisfying relationship with another person or people, and you can't assume that somebody is heterosexual. You can't assume that a wedding ring means that somebody is married to a opposite-sexed individual. So make sure that you invite those questions out, and your questions are going to put somebody at ease.
When my wife was pregnant with our daughter, the woman at the front desk in the gynecologist's office every month said the same thing. "Hi, Mrs. McKeown, has your husband's insurance changed?" And every month I said, "Nope, still gay." Right? And you would think that after the first few months, but she didn't. So I think that that there's things that people can do, with their language and things like that are just more inclusive. Can't keep up, but you got to keep open, and you got to stop making assumptions about who people are.
What are some issues and risk factors that members in the LGBTQIA+ community may face, and how do they vary among the different identities and intersecting groups its members belong to?
One of the largest issues we have as a community is discrimination. And so there's discrimination in healthcare access, in housing, in education, in employment. In every way you can imagine, there's discrimination, and that limits the ability of people in our community to flourish. And all of those societal things are leading people to become suicidal. And I think that's the probably number one thing that I'm most concerned about for transgender people, it's a 40% suicide rate. And if you add to it those who attempt and succeed, and those who don't attempt but think about it, you're probably in the 90 percentile. So most people who are dealing with gender issues have this as an issue as well. So it's a great opportunity for us to be an advocate, an ally, and for me, a better pastor. The other is for gay youth. Gay youth are 5 times more likely under the age of 24, I believe, to attempt suicide. So suicide is a real issue, and we can prevent a lot of that by welcoming, accepting, listening, and being good allies.
The suicide rates for young people without support, for gay kids and bisexual kids who do not have support, is in the low 30s. When they have family support, it drops down to about 7 or 8%. For trans youth without support, the risk factors are in the low 50s. And with support, it drops down to the low 30s. So there's still a significant risk factor, and that risk factor continues over the lifespan for trans folks. As young people, the risk factors are associated with family support or rejection. It's not just family that from which people experience rejection or harassment. You know, it's in the community, it's in their community of faith, and so on. I also think that race and ethnicity plays another level it's a level of intersectionality. So a person who is, let's say, a black Christian who's gay has 3 core identities to try to balance. And sometimes those identities are in conflict with each other, right? And so one of the groups of people that is the highest risk in the United States is black transgender women. And last year, 25 transgender women of color were murdered in the United States. Substance abuse rates tend to be higher among the LGBTQ plus community than among the straight and cisgender community, partly as a self-medicating response.
A major risk factor is having good access to medical care. So if somebody is a cisgender person, that is somebody who feels in line with the sex that they were assigned with birth and their gender identity are a match, but identify as lesbian, gay, or bisexual, they pretty much have the privilege of being able to walk into a doctor's office and getting good medical care. If somebody is transgender or non-binary, it's a little more difficult to walk into a doctor's office and say, so I'm presenting this way, but I was assigned this at birth. How can I get good medical care? Are you the right provider for me? Have you worked with transgender or non-binary people before? Do you know what my needs are? That's a huge risk factor. Another risk factor affecting the transgender community, particularly the transgender community of color, is safety and violence. The numbers of trans women that are being murdered and abused and attacked are astronomical, and that's a huge risk factor that needs to be addressed across the board.
Medicine has not been particularly good about understanding being culturally competent of the LGBTQ community's risk for HIV. For instance, a young black gay man in the United States, his relative risk of becoming HIV infected is 1 in 2. Transgender women are 49 times more likely than cisgender women to become HIV infected, and it's estimated that 50% of all trans women of color are already HIV positive in the United States. If you're stigmatized and you already have bias against that community, and then they show up in your office, your ability to care for them is blocked by the bias that you have. So I think that is one of the issues that has affected HIV treatment and as well as HIV prevention for LGBTQ people. And it's something that is it's across all sections of the LGBTQ community, and it applies to basically everybody's ability to get HIV prevention services.
And if we want to talk about intersectionality, the greatest risk in our community are trans women of color. So the intersection of misogyny and race and poverty and being transgender all come together in that moment, and people are murdered simply because somebody can't accept who they are, or they've been surprised by the gender identity of someone they didn't suspect, or they assume differently.
What can be done to make our healthcare system more accessible, reliable, and supportive for this community?
The first thing that has to happen is that in the training of medical care professionals, that people need to understand that LGBTQ plus people have the same and unique needs across the lifespan, right? And that, you know, if you are learning about prostate cancer, for example, then you should be learning about prostate cancer or prostate cancer risks for transgender women who still have a prostate. And so those conversations need to be inculcated across the education process for medical providers. The second thing that needs to happen is that insurances need to cover procedures and medical interventions that are necessary, especially for trans and non-binary folks. That often, you know, Husky's actually pretty good in terms of its coverage, but it's also, there's gaps in the coverage, and that needs to be addressed. And one of the gaps in the coverage is the numbers of providers who are competent to do it.
It's very important that particularly medical providers get trained, have understanding in what it means to be LGBTQIA, what the health factors are that are associated with the community, what the needs of transgender individuals are medically, to be able to better service the community as a whole.
There's less research on LGBTQA people in terms of health outcomes. There's maybe misconceptions and some bias that may still linger. And then what are their unique health needs? And creating an environment where it's comfortable to speak plainly and openly without fear that that person won't be served, or they will be served in a way that isn't competent culturally.
My first suggestion is to improve medical education, whether it's for nurses, medical assistants, physicians, NPs, PAs, whoever is going through medical education. Currently, in medical schools, the requirement for LGBTQ related issues is 4 hours over 4 years of medical school training. So that's not enough in my mind when you consider that probably 1 in 10 people is somewhere in the LGBT community in the United States. So that's sort of like saying, we only care about you for 4 hours, right? So, and there are huge healthcare issues that face LGBTQ people that are specific to that population. In terms of accessibility, it improves accessibility because people will want to come to my office if I am nice to them and I respect them. People will continue to come to my office if I'm nice to them and respect to them, and they'll get better healthcare overall if we're nice, if we have cultural competency about them.
Is there anything else you would like to say to the DSS employees to help them foster an inclusive environment for their LGBTQ coworkers, friends, and or family members?
All you have to do is understand a little bit of cultural competency about that, the LGBTQ people, and understand that they've been a lot of trauma in that community, and sort of like a little kindness goes a really long way for queer people. The bar is set very low for you as well, so like you don't have to be like fantastic, you just have to be like okay in order to have like a great experience with queer people.
The hard part sometimes is to let people know, how to let people know that they are included and accepted without making them feel different. So an experience that is often defined by people in the community is that they feel othered. And that's important to know, is that with acceptance and inclusivity sometimes comes this very exuberant acceptance, loving and all that, which can make somebody feel very different and excluded, even though the intention is to help somebody to feel included. So it's important to find the right balance of how do I let somebody know that I accept them and I include them without making them feel different.
Everybody is seeking to be authentic, so we really have that in common. All of us want to live a happy and flourishing life, so we're really not so different.
Number one, you don't have to keep up, you just have to keep open. And number two, you don't have to understand, you do have to accept and respect.
I hope that all of us continue to be inspired to move forward in time as we change. Our cultural mores are not static. Things we may have believed at an earlier juncture in time, or things that we may have understood growing up, things are changing in our culture, and I'd hope people can approach that from a sense of opportunity as opposed to a sense of fear or loss, and to approach it in a way of learning. We're all growing constantly, and the opportunity to connect more deeply, to understand, where we all come from, what motivates us in this common work of serving people, will help us connect better as team members and colleagues, but also, gives us incredible strength in supporting the over 1 million people who are served by DSS. So I think of that as an incredible sense of opportunity.